it came to my attention at lunch that with some of the certificates, and it's very difficult because we had a list of everybody's attendance, but perhaps some people registered after we got the list. Some of the names were misspelt. So what I'd ask you to do is if you didn't get a certificate, take your name tag with your name nice and clearly written and put a mailing address on it and give it to me. Like, I can't produce a certificate this moment, but I'll take it back to the university and we'll print you one and I will mail it to you. If your name is spelt wrong, just take your pen and cross out the part that's spelt wrong and correct the spelling and put your address on it and give it to me. So, I'll take it back, and, it's going to take you about a week to get it back, but I will certainly do that for you. So what we're going to spend a little bit of time on right now and is talk a little bit about some of the particular concerns around residents who have dementia. And we've already made the point that dementia is a very, very common issue for residents within long-term care. In fact, the majority of residents do have dementia, and it's because one of the reasons people can't safely stay home is because they have dementia. So it tends to be one of the things that contributes to a decision to make an application and enter long-term care. Dementia is also very complex, and it's a very broad kind of category that includes many, many, many unique different kinds of medical profiles. So dementia isn't one thing, and it, of course, has physical, psychological, social components. And these components are the consequences of dementia, which, as you know, is a brain disease. So it's very common. In Canada now, 500,000 individuals are living with dementia. And here's the statistic, 57% or more residents of long-term care have dementia. And I would say that's overall, but if you think about palliative care and as their care progresses over time, by the time you're reaching that end-of-life phase, it would be higher than that very, very often. And over 2/3 of deaths of individuals with dementia occur in long-term care homes. And that's because, as I said, long-term care homes provide a safe environment for people with dementia because they need 24/7 supervision. And long-term care is the setting of healthcare where we can provide that. As I said, dementia is a very, very complex situation. It initially affects the cognitive functions of the individual, but in time leaves people unable to communicate and care for themselves. And it's the challenges in communication, if one theme has been repeated again and again today, how important communication is to the relationship that staff develop and the relationship between residents and families. We've talked about advanced care planning, all of those kinds of things depend upon communication. So when the communication gets compromised, it creates very, very complex challenges. In addition to the highly variable characteristics that people with dementia have, the progression of the disease varies very greatly. Some people seem to progress very, very quickly in their illness, and some people can remain quite stable for many, many years, or it progresses very, very slowly. But dementia, Alzheimer's disease, is a progressive disease, and it is a terminal illness. So people with Alzheimer's disease can benefit by palliative care, just as people with other chronic diseases can. Dementia also has some undesirable consequences for the individual because it's challenging, because it's complex, because there are communication difficulties. Individuals with dementia, you have to work a lot harder to understand what it is that they want and need, and you can't do it often quickly or through conventional methods. So often if people aren't willing to take the time or don't take the time, individuals with dementia can be shut out of decision making. And that's not a good thing. That's not right. But they are harder to care for because of some of these challenges. And so people with dementia, it may not be as motivating for staff to care for them, and it's much harder for them to find ways to develop the kind of meaningful relationships we know are very important. If you haven't done, remember we talked about all that advanced care planning and what people's wishes were. If that hasn't been done early, you've really lost a lot of opportunity to do it as people's dementia progresses. And it really then is left to the family member, who is often the power of attorney for personal care, the substitute decision maker, to express on behalf of that resident what they think their wishes were. And I can't tell you, we interviewed a lot of family members for this study about their perceptions and their experiences. And without exception, every single family member said, I wish we had had these conversations earlier with my family member when he or she was able and to be more participative. And they felt really a lot of angst and ethical difficulty because they wanted to do the right thing, but they didn't really always know, well, what would my family member have really wanted. However, dementia also provides opportunities, and how do we make that shift to engaging older people in the kind of decision making that you can do in other unconventional ways? And that's by really, and Marg said this so eloquently, how personal support workers in their day-to-day work observe all of the behaviors of the resident, and you know, not all, most communication actually isn't verbal. It's body language. It's how people interact. It's their facial expressions. And by observing very, very closely those kind of behavioral signs, you can really help that individual person with dementia even participate and get involved. And that's really what resident-centered care is all about. Resident-centered care for all residents, including people with dementia. And person-centered care has been one of the most important contributors, I think, of the dementia care community to our thinking about person-centered resident care. But the resident is always in the center, and that speaks to the point someone made earlier about my slide, and should be communicating out to staff, family, and community partners about their needs and about their preferences. When a resident has dementia and is unable to communicate their own wishes clearly, they would commonly have their voice provided by a substitute decision maker. And the treatment decisions under the Healthcare Consent Act would have to be agreed to by the substitute decision maker on behalf of that resident. So that person acts on behalf of a resident who is unable to act on their own behalf or speak on their own behalf. So we talked quickly about these level of care forms that are very, very common in long-term care homes in Ontario. And one of the things to appreciate is that these level of care forms actually cannot be required. I mean, homes often will provide this form to a family member on admission and more or less insist that that family member or resident, if they're capable, but now that we're talking about residents with dementia, that family member make a choice about level of care and whether they want extreme interventions and hospitalizations, or do they want comfort care. And in fact, that isn't legal according to Judith Wall and the Advocacy Center for the Elderly. It is a choice and family members can choose not to complete them, or they can choose to take it home and think about it for a while and bring it back. Homes like to have them quickly because I think in some ways it makes people feel more confident that in a case of an emergency they would know what to do. But when you realize that these forms don't constitute legal consent for treatment anyway, they're just actually the wishes or the perception of what you would do. Legal consent has to be very specific to the incident at the time and what the decision is to be made. So an advanced care plan that says I want to go to hospital or I don't want to go to hospital will not replace having that conversation with that substitute decision maker or power of attorney for personal care at the time. So, and the other thing that I want to say is that competency is actually a moving target. So under the legislation and under competency assessment, an individual can be competent to do one thing, like know what they want to order for a meal or decide what kind of purchase they might want, but they might not be competent to make another kind of more complex decision, because people have to appreciate the consequences of their action in order to make that decision. So people aren't sort of generically competent or not competent. They're competent in certain ways and perhaps not competent in other ways, and you can't make that broad generalization. The other thing is that it fluctuates. So people may be competent to make a decision one day and they're having a good day, and another day when they're having a bad day, you may not feel they're competent to make that decision. And all of this adds to the complexity, but heightens the importance of ongoing communication with that resident and family about what they want, and really challenges us not to make assumptions based on what somebody said at the time of admission, what somebody said on a form. So I'm going to turn it over to Deb, and she's going to talk a little bit about pain, because pain is one of the most important symptoms. We talked about the need.
Thanks. So we've got about 10 slides to run through on pain, and then we might take some questions about your experience of trying to assess people's pain and perhaps some issues that you have with that. So pain is a subjective experience. It occurs when and where the resident says that it does, and even for people with dementia, that's sometimes still possible for them to communicate that. So people with dementia are less likely to report pain, partly because of their diminished cognitive ability, but they are no less likely to experience pain. And there was some work done a number of years ago by a scientist who actually queried that and thought that part of the dementing process meant that people didn't feel as much pain, and that was fairly controversial when that was published, and I think fortunately that has been debunked. People with dementia do experience the same level of pain as everybody else. Studies have found that professional caregivers tend to underestimate people's pain's severity, but family members tend to overestimate and overcompensate. So I don't know if there's somebody nodding here, maybe that's but your experience. So between 45 to 83% of people living in long-term care can experience acute or chronic pain. So acute pain would occur when there's been some sort of event, like particularly when somebody might have a fall. But chronic pain, people can live with chronic pain for many years, and probably most of the people that you're caring for are coming in with chronic pain. That's often under-recognised on admission as well as they progress in their disease. Pain is often from musculoskeletal issues like arthritis, as I say, but can be acute following a fall or another event. So one of the things that we came up with when we were trying to sort of, give people an easy way, and I know Mary Lou's in the next session, you've got something on your tables that they've come up with, but what we came up with was this thing which was see, say, do, write and review. So if you remember those things, is what do you see, what should you say to somebody, what should you do about it, what should you write about it, and then to go back and make sure that you review what's been done. So I'm just going to work through those things in the context of people with dementia. So seeing, recognising and assessing pain. People with early dementia can sometimes complete these tools. So don't think that they can't. It's sometimes a good idea to actually see if they can, particularly the verbal descriptor scale. So that's when people actually, you read out the words, have you got mild pain, moderate pain, severe pain, very severe, worst pain, rather than the rating scale. So as I say, some people can still complete these sorts of scales. Facial expressions, vocalisations, body language, behavioural change, physical changes are all the things that you need to be looking for, and there's a number of tools that do that. If you're not using a specific tool, these are the sorts of things that you should be looking for vocal, moaning, crying, calling out. I'm sure you're all very familiar with this. The body language of people, behavioural change, and I've put quieter there in red because sometimes we forget that somebody who normally paces around, and we all know those people who pace and pace and pace and pace, what happens when they stop pacing? And why have they stopped pacing? It may be that they're actually in a lot of pain and actually to do that pacing behaviour. So it may actually be easier for you to manage those people because they're not pacing, but you do need to think why has that behaviour change happened and do a pain assessment. So as I said, facial expressions, vital signs are all important. So we use the Abbey Pain Scale in Australia, which has numerical ratings against all of these. Here you can use the pain ad. There's a variety of pain scales, and really it's up to your home as to which one that you use. One of the things that you need to look for also is when you're doing a good pain assessment for people is to not only do it when they're sitting still or when they're in bed, but to do what we call a movement-based assessment. And that can be fairly simple. It's just as simple as getting people to sit on the side of the bed, to put their arms up, to perhaps stand up if they're able to, and so that you're actually getting some idea of that they've got pain on movement. So when they're lying in bed, they may not have any of these signs and symptoms, but as soon as you go to get them up, to go to the shower or do anything else, that's when they're in pain. And that needs to be taken into consideration. So what sort of pain might it be? And for those that you can't read the caption here, it says it's a stabbing pain as he has a dagger in his chest. So nociceptive pain is caused by damage to the body tissue and usually described as a sharp ache or throbbing pain. And so that's usually the pain that you see. But do people know what neuropathic pain is? So that's pain that goes along the nerve tract. And have you ever had shingles? Do people know what shingles is? Yeah, okay. So shingle pain is neuropathic pain, and it's actually really hard to manage. So if you've got people who have got a pain around their nerve endings, you may find that your traditional therapies like your Panadol, your Tylenol, you call it here, may actually not have a great deal of effect, and you may find that people are on different drugs that you think, oh, I wonder why they're on that, and it's because their pain has been identified as more of this neuropathic pain. So it is important to try and gather from people, and you can do that by words, describe the pain to me, and if somebody says it's like a hot dagger, or it's like pins and needles, or that stabbing sort of pain, then that gives you a good idea of the sorts of pain that it is, and then you can be able to communicate that. So sometimes it's not enough to just say, that the resident's in pain to the RN or to the doctor. Try and tease out what's the words behind that pain, if the people are still able to do that for you. So the say, what do you say to the RN? Be specific. Report anything immediately that's severe. And don't wait to see whether the pain might get better. And I think that what I've learnt so far today is that you're all very strong advocates, and I suspect that you speak up straight away, which is fantastic, because you are the resident's voice. That's great. So things like when do you document in the notes? Do you write? Is that? Yep. Some homes. Yeah, it's the same in Australia. It's so if you do, if you are writing in the notes, then again try and be as specific as you can. So this one, Mrs. S appears to have pain. She grimaces when we transfer her from sit to stand. So that's that movement-based pain. This is not her normal behaviour. It's happened 3 times today. So very specific. That it's not a once-off. It didn't just happen once. And that she indicates that this is a new pain for her. So that's a lot of information in the written document that you can give to the RN, and then the RN can pass on to the doctor, rather than just saying, Mrs. S has got pain and you need to come and sort her out, is not particularly helpful to the RN and taking that forward. So be as specific as you can. Think back to those behavioural changes. So write any of that down, paint a picture for the registered nurse or anybody else that you're communicating with, or if you're communicating between yourselves, paint that picture for people from shift to shift, so that they're very clear about what's happening, and then you know whether your treatments are making an effect or not. But if you don't give people the right amount of information, they won't know that what you're doing is actually improving things. The do, which is managing the pain, so things like manually positioning, I'm sure you're very good at that, getting people comfortable, making sure if you're using lifting equipment that you get people in the right spot, being conscious of that. Other equipment that you might have that can prevent pain, pressure relieving mattresses, things like that. Avoid twisting or stretching of joints or muscles, and it's really hard when people have got contractures. I mean, imagine how painful that would be to have contractures, and so very gentle with that. Always provide the care that's directed in the care plan. So hopefully somebody's done a good pain assessment and has got that documented. And I guess if you're unsure about it, speak to your RN. The analgesics, I know you're not responsible for giving those out, but some of the simple things that people might be on are things like Tylenol or non-steroidal drugs. And as I said, if it's a neuropathic pain, they might be on something that you don't recognise for pain, but it's because it's affecting those nerves. And then people might be on stronger things like morphine and fentanyl, and I'm not sure whether this translates well to Canada, but I suspect it's mainly the opioids that people are on. And do you use patches? Yeah. Patches have been a godsend for residential for long-term care because, you know, that you put them on once every 72 hours. They provide a really good level of pain relief for people. You don't have to be putting, cannulas or butterfly needles into people and topping them up regularly. So they have been a really great step forward. So consider waiting more than 30 minutes after analgesic medication before giving any care that is known to cause pain or discomfort. And I'm sure you do that. So, you know, being mindful if, you know, somebody has to have a wash or a shower, or they're going down to the dining room or participating in an activity, and that you know that might cause them pain, to get the RN, get yourself organised and make sure that you have that good coverage of pain before you're beginning any of those activities. And heat is a good option that you can do as well. And I'm sure you've got other things that you have in your toolkit where you can provide comfort for people. So again, writing, documenting what you do. As I say, so it's not only the verbal handover, but the written. As I say, avoid general statements. And make sure that you write down what pharmacological and non-pharmacological therapies that you did. So you may not be responsible for administering the drugs, but if you've done quite extensive comfort care for your resident, like applied some sort of heat pack, or you've massaged their affected area, or you've changed their position, or you've done various things, then it's important to write that down. Write it down to see whether and how effective it was, because then the person coming after you can think, okay, they've got a similar problem, I know this worked, we can continue on with that and provide good relief for the person. So communication in terms of pain management is critical as well, as generally that we've talked about. And again, the review. So one of the common things that I see not done well when I look at charts in long-term care is that people identify the pain, they give it a score, they give some medication or do some non-pharmacological therapy, and then they never actually tell you what happened afterwards. And so you don't really know whether it worked or not. So reassess using your pain tool that you're using. If as I said, if it works, then that's great. And if not, well, what are the options? We've got to think through what else that might be required. That's it. So I might just ask if has anybody got any real issues about pain management for people with dementia that you want to share with the group? Do you generally think this is done well? Are you comfortable with how you manage pain? Yeah? Yeah, families have high expectations that you will keep the person comfortable all the time. Yeah. So education for families is important about, the process that it might take 20 minutes or 30 minutes for the medication to work, or we've got to try a variety of therapies. Yeah.